Hi and welcome to Pulmonology Read Aloud. This is the part 2 of the Glossary of ILD series where I have talked about the typical patterns of various IIPs on radiology and histopathology taken directly from the ERS 2025 guidelines. Because these patterns and these images have been described in this guideline paper, um, all the text and the images that you see in this video are from the article itself. So, we'll be talking about diffuse alveolar damage, pulmonary fibroelastosis, and lymphoid interstitial pneumonia in this video in the interstitial patterns. And we're also going to talk about the alveolar filling disorders like organizing pneumonia, RBILD, the diffuse ground glass in AMP, lipoid pneumonia, and some rare patterns. Let's talk about diffuse alveolar damage first. Now, the term idiopathic diffuse alveolar damage has replaced the term acute interstitial pneumonia. And this is essentially because when we are talking about the idiopathic variant of alveolar damage, then by calling it as acute interstitial pneumonia, we may be creating confusion with other acute ILDs. So, every ILD can have an acute manifestation which may be similar to alveolar damage, and that is why idiopathic diffuse alveolar damage is specified as a separate entity without a known cause. Now, this term AIP, which was earlier used, was also quite imprecise. And so now, this pattern of lung injury, which has both acute and organizing phases, is better described according to the newer 2025 guidance. Now, because idiopathic DAD was also is a very severe and acute manifestation. Therefore, a lot of these cases do not have biopsies, and because the mortality is so high with the surgical lung biopsy in such an acute presentation, the histopathological diagnosis may not be needed in a lot of cases, and radiology may be something that we have to be very clear about. This is how a diffuse alveolar damage pattern looks like. Now, when you look at this axial chest CT scan, you see that there are bilateral confluent patchy opacities, and these confluent areas are more like ground glass attenuation. Now, with the ground glassing happening here, there's also some subtle distortion, and this distortion is also visible in the subpleural areas, like in this case, in the left lower lobe. And this bilateral, usually symmetrical kind of patchy consolidation or ground glassing also has a lot of focal sparing. So we will see intervening areas which look normal and intervening areas which are looking like ground glass. The consolidations usually look mostly dependent, so in the lower lobes, and there may also be traction bronchiectasis or bronchiolectasis. So this kind of a pattern of an acute presentation is called a diffuse alveolar damage pattern. Now, because it's divided into two main classes, the organizing diffuse alveolar damage and the exudative phase diffuse alveolar damage, the histopathology is different. And as I said, histopathology may not be warranted or possible in a lot of these cases, but what the lung biopsy shows is usually a thickening of the alveolar wall by connective tissue, by loose organizing connective tissue and some hyaline membranes. Now, in acute diffuse alveolar damage, which is the exudative diffuse alveolar damage, you can see that these connective tissue, loose organizing connective tissue, is more common. But when we go to the organizing type or of diffuse alveolar damage, we see diffusely thickened very prominent hyaline membranes, and usually edema and connective tissue, which is also organizing. And it comes along with thickening of the septa, it comes along with interstitial edema, and it's usually seen also as connective tissue in the alveolar walls. And this is classical of diffuse alveolar damage versus an organizing pneumonia, where there is intraluminal connective tissue aggregates, not in the walls itself. The next entity which is described is the pleuroparenchymal fibroelastosis, and this was initially described in the 2013 guideline as a rare entity, but now it is being more and more recognized. It is also being recognized in isolation and with other interstitial pneumonias. So sometimes it can be idiopathic and sometimes it can be associated with secondary causes. And when it's associated with secondary causes, usually you will see other coexisting patterns along with PPFP. You may see UIP or NSIP or BIP also. So pleuroparenchymal fibroelastosis, what do we see? We are going to look for upper lobe predominant fibrosis. We are going to look for subpleural nature of thickening and consolidations in the subpleural space. And as I said, both idiopathic and secondary may exist. So you may see it coexisting also with other patterns. This is the classical CT image of pleuroparenchymal fibroelastosis pattern, which has been given in the ERS 2025 article. And the radiological hallmark of this pattern is biapical subpleural parenchymal fibrosis. So both sides usually symmetrically subpleural fibrosis and pleural thickening. And this fibrosis usually here manifests as dense consolidation. It may manifest with traction bronchiectasis in the subpleural space and also reticulation and architectural distortion. But although it starts in the subpleural space or the apical space, a lot of times it may also be more widespread. And so PPFE has to be differentiated from an apical consolidation, because it may look like a subpleural consolidation, but you will also see the fibrotic elements and you will also see the tractional dilatation here. So upper lobe volume loss, fibrosis, involvement of anterior and posterior lobes, sometimes extending to the major fissures, may also extend to the middle and the lower lobes. So now it's included as an interstitial pattern, but it will also have some component within the alveoli and within the distal airways, is something that one has to remember. Now, when we talk about pleuroparenchymal fibroelastosis, we may get subpleural intraalveolar fibroelastosis, and this is termed as IAFE, intraalveolar fibroelastosis. So, in intraalveolar fibroelastosis, you may get pleural fibrosis, so you will get pleural thickening and a lot of fibrosis subpleurally, but also infiltrates deep within the lung parenchyma. So that is why the name is given as intraalveolar. So this will not be seen if you're dealing with just an apical consolidation, but here you will get not only alveolar involvement but also subpleural fibrosis. And most frequently, although it is subpleural predominant, sometimes it can also have a central distribution. So, pleural fibrosis with subpleural intraalveolar fibroelastosis can extend deeper into the parenchyma, and it is elicited with a lot of stains. The first one is HE stain, the second one here is elastica Mason stain, and this is a high power view of the same, where it may show intraalveolar collagenous fibrosis and elastosis. So, elastosis will be very prominent. It will be more prominent than collagenous fibrosis, and that's how it is seen histopathologically. Coming to the next pattern, the lymphoid interstitial pneumonia. Lymphoid interstitial pneumonia is a spectrum of reactive pulmonary lymphoid hyperplasia. So, very rarely you will get it as an idiopathic, and it will mostly occur secondary to other problems like connective tissue diseases, especially when we're looking at Sjogren syndrome or SLE or rheumatoid arthritis, in a lot of immunodeficiencies, HIV, EBV virus, and other immune disorders. So, lymphoid interstitial pneumonia is usually observed as bilateral ground glass opacities, and a lot of times there are random cysts. And because it's rare, we again a clinical workup, a serological workup, and correlation has to be done to exclude secondary causes. So when we look at lymphoid interstitial pattern, in lymphoid interstitial pneumonia pattern, what do we see? We see a bilateral ground glass opacity that are usually diffuse. But sometimes you may also see patchy ground glass opacities. And you may also see nodules which may be centrilobular, which may be subpleural, or which may be along the bronchovascular thickening. But what we typically also see are cysts. So, randomly distributed thin walled cysts are very, very common. You can see these randomly distributed cysts, and these are common in 70% of the cases. But there have been studies where they've mentioned that there may actually also be a lot of cases that do not have these cysts. So, since lung biopsy is not frequently performed, this typical presentation is something that one has to be very aware of: the ground glassing and these thin walled cysts. This is the histopathological image, the HE stain, and what it shows is a lot of alveolar um, infiltration, an interstitium which is infiltrated with lymphoid cells and lymphoid aggregates. And these lymphoid cells, they are lymphocytes, there are some plasma cells, and the diffuse infiltrate of lymphocytes and plasma cells extends and expands and distorts the septa, and it also has a lot of reactive lymphoid follicles. What is the distribution? Bronchovascular or lymphatic. And do we have fibrosis? Not much. But again, it depends on what is the primary cause. Sometimes when we are dealing with malt lymphomas, or when we are dealing with other immunodeficiency related diseases, there could also be other manifestations, and there could be solid nodular masses that have to be differentiated and excluded. So, in a typical appearance of lymph, we'll see diffuse infiltration of lymphoid cells and lymphoid aggregates. And in CT, we would see multiple cysts, bilateral, thin walled, random, with mild ground glass attenuation. Let's now move on to the alveolar filling disorders. These are very common patterns like organizing pneumonia, RBILD, a PAP pattern, which is now called as AMP, Lipoid pneumonia, and rare AFPs. So let's see them one by one. The third pattern is the organizing pneumonia pattern. And we know that organizing pneumonia can be idiopathic, such as when we call it COP or cryptogenic organizing pneumonia, or a lot of times it is associated with an underlying condition. And most commonly, this underlying condition can be post infectious, it could be connective tissue diseases, it could be drug induced. Now, this ERS 2025 does retain the term cryptogenic because it denotes that it refers to idiopathic organizing pneumonia, because it is used so much in literature that this term has not been made obsolete and it is retained. But it's important to understand that whenever we diagnose it, we are ruling out certain causes, and it is supported by a rapid and sometimes complete response to corticosteroids. But then again, there is a variability in this presentation, in this response to treatment based on the etiology, and it also has a very high level of recurrence. So, what do we see on the radiology? In organizing pneumonia, we expect subpleural and sometimes extension to peribronchial or it could be peribronchial consolidations or ground glass opacities. Ground glass or consolidations, again, subpleural or peribronchial. And as I told you when we were talking about PPFE, that here, again, it could be subpleural just like that. Now, a lot of times you may get ancillary CT features. A lot of times you may get a tree bud opacity, such as in a fungal infection, or you may get cavitation when there's associated tuberculosis, or you may see other findings such as an alveolar hemorrhage component, and that usually suggests that there is a etiology to it. So you can get a focal mass, you can get nodule, you can get an air bronchogram in this subpleural consolidation, and you may get variety of patterns. One of the classical pattern is the reverse halo appearance and perilobular thickening, but it is not the only pattern that you would expect. Again, it's migratory on serial imaging and classically resolves beautifully to steroids, but may not be the case in all the cases if they are especially secondary ones. So, this is the CT image, and classically, you see a consolidation and ground glass attenuation in both the lower lobes. There are also areas of lobular sparing, and what it also shows here is ground glass associated with a reverse halo sign in the anterior segment of left upper lobe. So it could manifest as reverse halo, it could manifest as consolidation with ground glass with lobular sparing, and it could also manifest with vascular sparing, like in this case. The vessel is very clearly seen in that area of ground glass, and in that area, typically you are seeing it very prominently. So organizing pneumonia pattern can again manifest in various ways, but these are usually the typical classical presentations. When a lung biopsy is done, we see in organizing pneumonia that there are polypoid intraluminal plugs of loose connective tissue inside the alveolar ducts and alveoli. So it's not in the alveolar wall, but in the alveolar duct and alveoli, we see loose connective tissue. And we also see that the presentation is very patchy. Now, usually here we don't see any interstitial fibrosis because the inflammation may not be very conspicuous. And what we also see in histopathology is the vascular sparing. So, there's a relationship with the veins and the lymphatics, and the mucus, the polypoid plugs of loose organizing tissues are usually seen on sides of the vein. So, that's also very typical of organizing pneumonia. Now, this is a beautiful table where the organizing pneumonia and acute fibrinous organizing pneumonia and another pattern of organizing pneumonia, which is more cicatricial. The cicatricial organizing pneumonia is beautifully defined in this table. So, typically in an organizing pneumonia, classically, we see diffuse multifocal consolidations, ground glassing, perilobular, halo or reverse halo sign, also called as atoll sign or mixed sign, with or without additional features like nodules, mass-like lesions, or masses with a halo sign or bands. Histologically, as I said, polypoid plugs of loose connective tissue in the alveoli, ducts, and respiratory bronchioles, and the interstitial inflammation is less prominent in such a case. Now, these are usually migratory, they can relapse, they have a lower lobe predominance, and they spare the vessels, they spare the lobules, they spare the subpleural space a lot of times. They are migratory, peribronchovascular, bronchocentric. And the differentials could be the cryptogenic variant or secondary to multiple causes. When we talk about the acute fibrinous organizing pneumonia, in acute fibrinous organizing pneumonia, in this histological pattern, there is a spectrum of pattern which is ranging between organizing pneumonia and diffuse alveolar damage. So there is some fibrinous involvement also. So it's close to or in between of organizing pneumonia and that component. Now here also a lot of these cases are secondary, but they can also be idiopathic, and you can get mass like ground glass nodules here with a tendency to coalesce. And here, these patchy mass like lesions or ground glass opacities on imaging, they correspond to intraalveolar fibrinous balls. So, intraalveolar fibrin forming balls in within the histology of organizing pneumonia. A lot of times, organizing pneumonia can also come along with other patterns like the mixed pattern, like often with NSIP, and they can also progress to a fibrotic variant more like NSIP. So it can start with organizing pneumonia and progress to fibrotic NSIP. In that case, you see a combination of fibrotic NSIP and organizing pneumonia, and this is histologically called as fibrosing organizing pneumonia, or it may be called as cicatricial organizing pneumonia when all these polypoidal plugs, they have dense fibrous tissue also, and it's usually also defined classically as dendritiform ossification. So sometimes you have a dendritiform ossification, often in the perilobular space. So, dense fibrotic bands like cicatricial bands, intraluminal polypoid plugs, and dendritiform ossification. On CT, you will see it with reticulation and pulmonary ossification. Again, it could be idiopathic cicatricial or it could be secondary to multiple causes. So, this is organizing pneumonia pattern. So this is the variant, the acute and the cicatricial variant. Now, when you look at the acute fibrinous organizing pneumonia, you can see multiple nodules and rounded consolidations. And the distribution is bronchovascular. It is in the bronchovascular bundle. When you look at chronic or a cicatricial organizing pneumonia, you are also seeing what we are also seeing is the thickening of interlobular septa associated with dendritiform. So it's like the neurons. So look at this pattern: dendriform ossifications, mainly in the peripheral and the basal lung zones, right? And when a biopsy is done in acute, you will see balls of fibrin filling the alveolar spaces, and in a cicatricial one, you will see polypoid plaques, which are collagen material and more like ossification. So, bone like bone metaplasia. That is what is visible. The next pattern is the RBILD pattern, and RBILD or respiratory bronchiolitis associated ILD pattern is again a pattern which is associated with bronchiolar-centric distribution with patchy and poorly defined ground glassing, often in centrilobular pattern. Now, this is also associated with involvement of alveolar ducts and peribronchiolar alveoli containing the pigmented macrophages and accumulation of macrophages in the alveoli. Now, patients in almost 93% cases with a histological RBILD pattern will have smoking as a major risk factor. And there are, although few patterns, few patients where it could be idiopathic. So, in patients who are smokers with this pattern, it will be labeled as respiratory bronchiolitis. And when there is interstitial fibrosis associated, it will be labeled as respiratory bronchiolitis associated ILD. And in such cases, there may be coexisting emphysema, and then in that case, it will be called as AEF or air space enlargement with fibrosis histopathologically. So, respiratory bronchiolitis associated ILD, RBILD with fibrosis, smoking related interstitial fibrosis, there can be multiple descriptions of the same. So this is the RBILD pattern, and on CT scan we see scattered centrilobular ground glass nodules in upper lobes as well as lower lobes. So there are ground glass nodules which are scattered, but usually no fibrotic distortion visible. On lung biopsy, we see bronchiolocentric accumulation of macrophages and excess of macrophages, alveolar macrophages filling the alveoli is usually a diagnostic feature in RBILD. Let's come to the next pattern, the alveolar macrophage pneumonia or AMP pattern. Now, DIP, which was initially described as desquamative interstitial pneumonia, has been changed to alveolar macrophage pneumonia. And this is because the terminology DIP was very inaccurate pathologically. The cells here are macrophages, they are not desquamative pneumocytes. So, the name has been termed as alveolar macrophage pneumonia. Again, like RBILD, lot of these cases are smoking related, but it can also be idiopathic, it can also be secondary to other causes like CTDs or occupational dust exposure, and also in so smoking. This is the alveolar macrophage pattern. When you look at the CT scan, you see patchy areas. You see patchy areas of ground glass attenuation in both lungs. And this comes in a background of paraseptal and centrilobular emphysema. You also see cysts that are scattered, like here in the left upper lobe. Now, alveolar macrophage pneumonia will commonly present as ground glass, patchy ground glass on chest CT scan. And this ground glass, how do we differentiate it from RBILD? It would be more confluent and it would be present primarily in the mid and the lower lobes. So, ground glass that's more in the mid and the lower lobes and will have a peripheral predilection. So, peripheral predilection, more confluent ground glass, patchy in appearance, with cysts and signs of emphysema, with sometimes some fibrosis, but usually uncommon honeycombing. That's how AMP usually presents. Sometimes you may also get centrilobular nodules. Pathologically, the lung biopsy usually again shows, like the name suggests, diffuse expansion of alveoli with macrophages with some chronic inflammation. And the major feature would be, however, this alveolar macrophages filling the alveoli. So, diffuse involvement, uniform within the air spaces, and diffuse arrangement of macrophages. It can be common in both smokers and non smokers. Sometimes you may actually, on histopathology, see black carbon particles in the macrophage cytoplasm in smokers. So, a lot of features that may actually overlap between RBILD and AMP. But AMP can coexist with UIP, it can exist with NSIP, and it will have more dense, confluent, patchy ground glass. Coming to lipoid pneumonia, the appearance here is of a middle lobe and lower lobe irregular presentation. So you can see how there are irregular architectural distortion and septal thickening. So this septal thickening and irregular distortion is characteristic in lipoid pneumonia, and usually lipoid pneumonia has vacuolation on histopathology. Coming to combined patterns, I have been mentioning again and again where one pattern can coexist with NSIP or UIP. So, this guideline statement takes into account that a lot of times you may have combined patterns. You will have multiple patterns like an NSIP with organizing pneumonia or a UIP with a PPFE. In that case, it's advised that we should treat the dominant or the more aggressive component first. This is a beautiful table of some rare alveolar filling disorders. These include eosinophilic pneumonia. The pattern in pulmonary alveolar proteinosis and LP or lipoid pneumonia. So, lipoid pneumonia, pulmonary alveolar proteinosis, and eosinophilic pneumonia. Eosinophilic pneumonia, we know clinically can be acute or subacute, and typically it's reversible, but when it becomes chronic, it may have residual fibrosis, and it usually shows as variable ground glassing. So, variable craniocaudal and axial distribution with ground glass or consolidation with septal thickening and peribronchovascular thickening as well. When we go chronic, we also see findings of linear band like opacities near the pleural surfaces and sometimes lobar atelectasis. Pathologically, an acute eosinophilic pneumonia will be like an acute lung injury, like a DAD or a diffuse alveolar damage pattern, just that it will not be idiopathic this time, and there will be alveolar and interstitial infiltration with eosinophils. The more the chronic it is, you may actually see coexisting patterns and you may see more eosinophils in the interstitium. In resolving eosinophil pneumonia after steroid therapy, in such cases, you may see patterns which look like organizing pneumonia or AMP. So, a lot of overlap in this pattern. PAP or pulmonary alveolar proteinosis, very classically defined as central lung ground glass opacities with crazy paving pattern. So, crazy paving pattern which has classical interlobular septal thickening and relative sparing of the apices and the CP angles. Here also we see accumulation of proteinaceous debris, and you may see secondary features of the primary pathology. In lipoid pneumonia, the presentation is usually variable and it's potentially reversible in the exogenous phase, and you may see variable findings. You may see ground glass, you may see mass like lesions, you may see central lobular nodules, you may also see crazy paving kind of a pattern in lipoid pneumonia. But here, the histopathology clinches the diagnosis with lipid laden macrophages in the alveoli and the interstitium, and the lipid is vacuolated in endogenous LP and more variably vacuolated in exogenous LP. These are the combined patterns. The first one that we see here, this is a pattern where there's a combination of NSIP and organizing pneumonia. So you see peripheral subpleural consolidations, you see NSIP also in the form of ground glassing. Now this here NSIP and organizing pneumonia will be in bilateral distribution in a peribronchovascular subpleural distribution here in this case. Now in this row, we can see a combination of pleuroparenchymal fibroelastosis in the upper lobes and UIP in the lower lobes. So here you can see the honeycombing and you can see the subpleural fibrosis, elastosis, and subpleural kind of a consolidative pattern. So fibroelastosis upper lobes, dense pleural subpleural fibrosis, and UIP. And here you can see a pattern where you have HP or hypersensitivity pneumonitis, the BIP pattern, and along with it you have emphysema. So again you see extensive emphysema, and you also see thin walled cysts with centrilobular ground glassing. So again a combined pattern. This is a summary of the common combined patterns. So UIP can exist with all of these, NSIP can exist with all of these, BIP can exist, and organizing pneumonia. So you see there's significant overlap in a lot of combined patterns. This is an image of pulmonary alveolar proteinosis, and we can appreciate how it is bilateral. We can appreciate the crazy paving pattern, the thickened interlobular septa. We can appreciate this component where there is minimal subpleural ground glassing, or rather there's a good subpleural sparing here. Eosinophilic pneumonia, again, we can see some acute and chronic. So, in the acute eosinophilic pneumonia, you see multifocal ground glass opacities and consolidations with septal thickening. It's more like a diffuse alveolar damage pattern because it's an acute presentation. But you see, there is no subpleural sparing here. It actually does involve the subpleural space. It's very dense. And sometimes it may also present with pleural effusions, but there is no fibrosis. When you look at chronic eosinophilic pneumonia, such as in these two figures, you see again an upper lobe predominant disease with a reverse halo sign. So, upper lobe predominant, but a reverse halo sign here, and we see interlobular septal thickening. This is a table taken from the supplement of this guideline paper, which talks about acute chronic eosinophilic pneumonia, PAP, and Lipoid pneumonia as the rare diagnosis. There still are 10% of ILD cases which are unclassifiable. You may not have a biopsy, or there may not be a consensus. And according to the guideline, these are the targets of involving AI in healthcare. So, with that, let's come to some key takeaways. We now have a classification in 2025 which is etiology inclusive. So, you have idiopathic and secondary variants of almost all patterns. It is also based on the disease. It also takes into account that there are secondary causes that have to be ruled out. BIP is the new major for airway centric diseases. AMP and IDAD have made naming these extensive alveolar involvement more specific, and we need a good diagnostic confidence, as mentioned in my previous um, video where I described the guideline in general. It's important to have a good more than 70% diagnostic confidence to start treatment. So, with that, I'll end this video here. I hope you enjoyed this glossary of ILD patterns. Hope to see you soon with another video. Till then, keep subscribing, liking, and sharing Pulmonology Read Aloud. Bye and have a good day.